All right. Good afternoon, everyone. Thank you for joining us. Yate, I'm Carrie Billy. Belladonna Nishni Oni Bashishan Dashishek Ani Dashanali. I am Carrie Billy, the president and CEO of AIHEC, the American Indian Higher Education Consortium, which is the 37 tribal colleges, and we are proud to be sponsoring the National Native Health Research Initiative and webinar series with our partners from the Indian Health Service. This is our second to the last in this particular series. So thank you for joining to hear about these important topics related to American Indian and Alaska Native health. We always like to start our meetings at AIHEC by honoring the first people of whose land we are on. And I know that we're located all over the nation and perhaps the world today, but I hear in the Washington, D.C. area, we are on the homelands of the Anacostans and Piscataway nations. We know many other people live here now, but I just want to say that I hope everything we do in the next hour or so honors the first people of this land, honors the care with which they lived on this land, their history, their past, and their future. And we also like to start all of our meetings in a good way. And I am so happy to introduce Camillus Lopez, who is going to give our opening prayer. Camillus is a member of the staff at Tohono Community College, which is on the lands, the beautiful lands of the O'odham Nation, which if you don't know where that is, it stretches out across what is now southern Arizona and into Mexico. Mr. Lopez is a respected elder and a storyteller, and at TOCC he provides important consulting and contextual services to the college's National Science Foundation STEM programs. And he's also a member of the HIMDOG committee, the cultural committee for Tohono O'odham. And he's helped AIHEC as we work through some of our initiatives with our Indigenous evaluation framework. And Camillus, I'm so happy and just honored that you're able to join us today. So thank you for invoking the spirit for our meetings.
Go ahead. Hika masota kanyai himaka, hika masota kanyai himaka, watoto itina, hika makako na kana na wanga tamai kake, tamai ngasota kanyai himaka. Watoto itina, wika masota kanyai himaka, wika masota kanyai himaka, watoto itina, wika makako na kana no anga samai kati. Tamai ngasota kanyai himaka, watoto itina. Wika makako na kana no anga samai kati. Tamai ngasota kanyai himaka, watoto itina. Wika makako na kana no anga samai kake, tamai ngasota kanyai himaka, watoto itina. Okay, na sama chatum pihai chuk tu chumuke pihai chuk matamo amot joint ki matama pat kamai choya kai no shragi de wa kamuchok chantam chupihas ko hai che ma ip ta good kamach ka. For all the things that we will learn today, for all the things that will be discussed, for all the things that matter to us, and for those things that matter in the world, for all our friends, our family, and for all those who require our assistance for our future, for those who are not yet born, and for those who have left us this great, great, great knowledge that we share. For all these things and the things that are dear to our hearts in this pandemic, as we cry out to you and hope in our future that you may be with us and give our hearts comfort so that we may learn and teach what we learn. For all these things, pray.
Thank you, Mr. Lopez, for that beautiful song and your beautiful, important words, and thank you so much for always teaching us the important lessons that you have to share. We are very, very grateful. Thank you.
Thank you.
Thank you. Okay, let's see. Am I sharing the right screen?
Yes, if you want to make it bigger.
There, do you see that?
That's presentation view, but it looks okay.
Yeah, let's just go with that, because what we're doing, I just want to again thank Mr. Lopez for that beautiful song and those words, and for as he says, invoking the spirit with us today. We have a few little things to mention that we're going to have all participants will be muted, but just in case, please mute your phones, computers, that sort of thing. We'll have questions and answers following the presentations, but you're welcome to type your questions into the chat box, which you will see on the screen at any time, or you can, if you're on a phone, email them to Maggie M. Grandin, it's MGRANDON at AIHEC.org. And she can read the question at the proper time. And just as everything is evaluated, we have an evaluation that will take place after each presentation, really quick evaluation just to help us continue to improve our presentation. So please take a few seconds to complete that evaluation, or it will also be on the nnhrti.org website afterwards if you don't have time to complete it, along with this webinar and the materials. So next, with that out of the way, I'm going to go ahead and introduce both of our speakers, Dr. Jamie Ritchey and Dr. Johnathan Davis, who are both with the Intertribal Council of Arizona Tribal Epidemiology Center. So the focus of our event today is learning about the tribal epicenters. Dr. Ritchey is going to go first, and Dr. Ritchey is the Tribal Epidemiology Center Director for the Intertribal Council of Arizona. She's served in that position for over 8 years, providing public health technical assistance and training for Indian tribes in the Indian Health Service area, the service area of Phoenix and Tucson. Dr. Ritchey has advanced training and technical expertise in epidemiology, design, methodologies, social and behavioral health, grant writing and reporting, program evaluation, and chronic infectious injury and behavioral health programming. So just about everything we need. So that's really great. And then joining Dr. Ritchey will be Johnathan Davis. Dr. Johnathan Davis serves as the Geospatial Data Analyst and Program Manager for the Intertribal Council of Arizona. He's been in this position for about 6 years, since 2014. He received his PhD in geography from Arizona State University just this year, so congratulations, that's really exciting. And his research interests include qualitative methods, evaluation, digital storytelling, geospatial analysis, community-based decision making, and geodesign, all the qualifications of Dr. Ritchey and Dr. Davis, really important things that we need while we're in this time of a pandemic and this new virtual world. So I'm looking forward to both presentations. Dr. Ritchey, would you like to begin?
Hi, good morning, good afternoon, depending on your time zone. Thank you, Maggie and Carrie, for the wonderful introduction. And thank you so much, Mr. Lopez, for getting us started in the right, good way. I would be remiss if I didn't take a moment and thank all of you for being here during such a trying time. We've all experienced loss. We've lost people that we care about due to this pandemic with COVID. Many people have lost their jobs and their incomes. Many people have lost a lot this year. So, I want to start off by acknowledging that. It's very important to make sure that we don't just look at data and numbers, but we remember our communities and how we're serving them during this time. So I want to thank all of you for being here. And in particular, I saw Selena, who's our past project officer for Indian Health Service at the Division of Epidemiology and Disease Prevention. Selena, thank you for being here. And also my colleague, Agnes Attakai, who is also in the state of Arizona. Thank you for being here, Agnes. Without further ado, I'm going to give two presentations today. The first one will be a general overview of all the tribal epicenters nationally. The second presentation, I'm going to hone in on some data and some information from ITCA specifically. And then I'll talk a little bit about some of our work with students, and then some of our work just in general at ITCA. It's not an exact fit, so I won't be talking about research today. I'll be talking about public health practice, which is a little bit different. You may have seen that throughout the pandemic, but ITCA has worked on research projects, just not as part of the tech. And some of the other tribal epicenters do research as well. So if you're a student and you're looking for future employment opportunities or internships or things of that nature, keep in mind, I'll be focusing on the public health aspect today, but there is also that research aspect in the background as well. We are a tribal epicenter program. We are working to advance public health in Indian country. 4 of our centers have been in operation since 1996, including the center at the Intertribal Council of Arizona. Maggie, next slide, please. Thank you. Our public health authority was established via the Indian Healthcare Improvement Act. The techs were not established as part of the Indian Healthcare Improvement Act, okay? The public health authority for the techs was. There was a recognition with the tribal leadership across the country, and then Congress, and then also the Indian Health Service, that there was a need for epidemiologic and public health services. So that's why the techs were formed. And we became a little bit more formalized under the Indian Healthcare Improvement Act by being granted public health authority by our tribal leadership and by our communities, and also by the US Congress. So we function independently, but also as part of a loose national group. And then our core funding that links us together is our cooperative agreement with Indian Health Service, Division of Epidemiology and Disease Prevention. Next slide, please. So you can see the map, of where we're located. I'm in Phoenix, Arizona. And you can see that in the orange portion with Nevada, Utah, as well as serving tribes there, with the exception of Navajo Nation. They have their own tribal epicenter. And my colleagues are working out of the Navajo Nation there. We do work together on various projects that we have in common, but we do function independently to work on meeting the needs of our tribes. Next slide, please. So back to that public health authority piece. In 2010, under the Affordable Care Act, we were permanently reauthorized under the Indian Healthcare Improvement Act, and techs were given this public health authority status. So under this, we don't have quarantining powers like county or state health departments would, but we do have the ability to have PII, which is personally identifiable information. And Health and Human Services directed to give techs access to HHS data systems and protected health information. We're currently working now to get access to the HHS Protect system. Our attorney had some questions. I've shot that back over to Indian Health Service and HHS to get those questions answered, but it does look like we'll have access to that. And under this, the Centers for Disease Control and Prevention must provide tribal epicenters with technical assistance. And they have been. We have a good partnership with Centers for Disease Control and Prevention. It's a positive relationship. We do have several cooperative agreements with them to build capacity, not just for our tech, but within our tribal communities as well, okay? So, you know, I'm interested in a ground up approach where we're working with the tribal health departments to build their capacity for data collection and information and their capacity for epidemiology and public health work. My passion is at the local level and building up that capacity because it makes you stronger, particularly in a pandemic. I can't be in 3 states and 44 communities with 10 staff, right? I can't. So it's critical that we build capacity at the local level to be able to respond to things like COVID. And our communities are collecting their own data, their own information, as it should be. Okay, as it should be, all right? And then we provide support as needed. And then each Indian Health Service area has a tech. Next slide, please. So again, under the Indian Healthcare Improvement Act for 2010, the reauthorization, you know, and that public health authority and how that relates to HIPAA and how that relates to data and information, you know, I want you to know that I'm very cautious about the information that we do take into the tribal epicenter. For instance, you know, ITCA is currently closed. We're all working from home. So a best practice is not for Dr. Ritchey to have PII within her home. Okay, that's not a best practice. So we're working on building up our capacity and our data systems internally at ITCA. You know, and Dr. Davis will talk a little bit more about our COVID activities, but just understand, you know, this public health authority is really functioning in a way to let us have access to PII. And I'm very sensitive to that. Next slide, please. So we do have 7 core functions. Maggie, I think these might pop up automatically. I'm not sure. They changed the slide deck. Yeah, here we go. So these are the general 7 core functions of the tribal epidemiology centers: to collect data, evaluate data and programs, identify health priorities, make recommendations on a variety of different things, provide EPTA to tribes and tribal orgs, and provide disease surveillance. I would say 4 tribes, not 2 tribes, but you know, these are our general 7 core functions. And then we of course do that and provide that support, you know, for our communities. We're of service to our communities for what they need. So our communities dictate what it is that we do. And I've got some information in my presentation for ITC I can cover, but this is more of a backdrop. Next slide, please. And, you know, we have to mention the essential public health services. Now, I wasn't trained on the essential public health services wheel, but it is a real thing that's out there, and what public health uses. And it is being, I believe, modified again, but I do think it's a good schematic that covers how research is related to these core functions in public health. So it isn't that public health is occurring in this vacuum without research. And I do think that I like this model. I think that it's a good basic model to show what public health does. I don't necessarily think it captures fully what the tech does. But, you know, there it is. Next slide, please. Oh, yes. And then we have the specifics within there and all of the different activities. We also have a national website where if you're interested in finding out more about what each one of the tribal epicenters does, you can click on our logos and, you know, different information will pop up about the tribal epicenters. ITCA, we have various success stories, on our website. We just posted one that Dr. Davis will be covering in his presentation. Next slide, please. And then, of course, our contact information is available here. Again, with the pandemic, response time may be a little bit slower than normal. So, if you email us, it may take more than that, standard 12 to 24 hours for a response due to the pandemic. But you're always welcome to email us if you have further questions. Next slide. Okay, so that's the end of the first presentation that I'll give. And then we'll go on to the second presentation that's focused on ITCA. Great. So again, if you're just joining us, my name is Dr. Jamie Ritchey. I'm the Tribal Epidemiology Center at Intertribal Council of Arizona. We're located in Phoenix, Arizona, and we provide services to tribes in Arizona, Utah, and Nevada. Next slide, please. So we conducted a survey of our tribal health departments. And in 2016, 2017, we got about 21 returned surveys. That's fairly typical for survey work that you'll hear from about half of your population. Next slide, please. So what I really wanted to know is, how can I be of best service to our communities, and what do the tribal health departments need technical assistance with? So, during this time, we really put forth an effort the year before to put out our first round of community health profiles. And our regional profile is available on our website. And then we provided what data we could find publicly to each one of the tribal communities. And, we used a series of race and ethnicity and geography to come up with who would be in each area. So you can tell that's a really cooked method, right? Like, it's not the best, but it's what we could use. And then we also had Indian Health Service data that would, have tribal information, which is why we did only provide those community-specific reports to the tribal health directors, and those are not available publicly because there would be some private information in there. So the numbers do get small within those reports. The regional report will give you an idea of some of the indicators we looked at. So, of course, going into that, health indicator development is important, data collection, and then you produce your profile. 65% of the tribal health directors that we surveyed after seeing these reports really agreed that we need to do something about data quality improvement. And this has really been a focus of the techs when we're working with our federal partners and some of our other partners across the country too, because if we don't have good data, we can't really capture what's happening quantitatively for our communities, and that can be a problem. So one way to overcome that is to work on data set linkage projects. So Northwest Portland Area Indian Health Board has worked on a series of data linkage projects, and so has IHS. And so, it works, it does improve the information, but it's not maybe the best way. I think going back to the data collection piece and working with our state partners may even be a better way. So at any rate, when our tribal health departments requested assistance, you can see where, those priorities lie. And data set linkage, it can be a public health practice activity, but it can also be a research activity. So if you're interested in research, understand that's an area that you could potentially be involved. Next slide, please. So in response to that, we have been working with other data sources that are available, including the Utah Department of Health's Women, Infant, and Children data. We're working on an Indian Health Service dental needs assessment. We sent our application back to IRB. It is now out of IRB. We're working with our dental centers to collect data. That data won't be available public. That's for quality improvement for the IHS dental centers, but just be aware that's a project we are working on. And then we've also provided training for digital stories for program evaluation, program health promotion, disease prevention, those types of activities, because we don't want to forget the qualitative piece either. And that extends beyond anecdotal information or story information. That does extend to focus groups and can-format interviews as well. Next slide, please. So from our survey results, the Public Health Accreditation Board requires these prerequisites, and they're in Community Health Assessment, or CHA, Community Health Improvement, or CHIP, and Strategic Planning. So, when we're thinking about public health accreditation, we do have tribes in our area that are interested in going through this process or are receiving public health accreditation now, right? So I'm interested in, how can we provide support? So, I thought for sure the community health assessment piece would be the area we would really be providing support. And as you can see from the data, I'm wrong. Strategic planning was really where our tribal communities were wanting assistance. So we did work with the Native American Cancer Prevention Group, and then several tribes that are part of that group, and University of Arizona to pilot our strategic planning toolkit with Bluestone Strategy Group. They're an LLC that's located in Phoenix as well. We partner closely with them on a number of activities. We constructed our first toolkit that's available online on our national website with that group, and have since gone through several iterations and revisions to that toolkit. Our strategic planning training remains very popular with our communities. And so we've provided several different trainings. We worked on opioids in that area and revised our toolkit for opioids as well. And that's available. So that's an area that we really hit this past 5 years. We've started moving into the community health improvement planning as well. We kind of got derailed a little bit with COVID. We were going to do a train the trainer activity session. And unfortunately, we weren't able to do train the trainer with our group that we were working with, but we have been working with Public Health Foundation through our tech fee program to build capacity in this community health improvement planning area. So the CHIP is another area where we're providing support through the Indian Health Service Cooperative Agreement and through one of our cooperative agreements with CDC. Next slide, please. So here's, some of the breakdown of sessions that we provided for technical assistance and strategic planning. Next slide, please. And then again, of course, our train the trainer got a little bit postponed, but we have been working on, we provided another training session with our communities that are on our tech fee grant just this fall. Next slide, please. Okay, I know this font gets a little bit small. I apologize for that. And this focuses on which areas does your tribe need technical assistance for health programming. So, it's not enough to know what people want you to do, but in what areas, right? So you can see substance abuse and behavioral health, it's quite high, right? Cancer, dental, maternal and child, injury, elder care, social network analysis. Dr. Davis is an ArcGIS expert, public health emergency preparedness. You see that's relatively low. I would be willing to bet if we did this survey now with COVID, everybody would say that could be a focus area, right? But 16% go, pre-pandemic. Disease outbreak support, 21%. Again, this also reflects the needs of our area. Remember, our communities want to build their capacity locally, right? So they may be working with the state, or they may be working with another agency like CDC to build their capacity locally for public health emergency preparedness and disease outbreaks. We have a fairly unique situation in Arizona where the state and DEMA work really closely with the tribes in Arizona, and they do provide funding to tribes. And I know that that's been an issue in other states in the country where tribes just are not allocated funding through the public health emergency preparedness funds the states receive. But in Arizona, we have a full working committee. They're very active. We do house some of their meetings at ITCA and support them with meeting support and different areas for disease response. We also had some diabetes prevention funding previously through Indian Health Service, and you can see that's of course still a focus for our communities as well. So those are some of the health areas that we continue to work in. Next slide, please. So for the surveillance reports that we can share, and some of the research articles that we can share that are available public, we have those available on our website, and this is just kind of a running list of things that we have. And then we're also working on a series of MMWRs, and that's really around data quality improvement, working with CDC in some of the states. So Dr. Davis will talk a little bit more about that. And then we recently had our Tribal Epidemiology Journal Supplement with Journal of Public Health Management and Practice, and we are planning another journal supplement coming up in the next year to showcase some of the good work that we're doing with our communities across the country. Next slide, please. So technical assistance requests on our Indian Health Service funds. We track all of our requests for technical assistance by year. This is one of our measurements that we report to Congress. So, what does that mean? Well, it can mean anywhere from, we provided mailed out boxes of masks and COVID posters, right? We provided hand sanitizer at the beginning of the pandemic to tribal police departments. We provided HIV poster printing for our communities that are participating in our Ending the HIV epidemic funding. So, this is very different across the board, and it's based on what our communities specifically need. We're a little bit, lower than FY 17-18 this year, but I think our requests were a little bit more intense during the pandemic, and they were a little bit more involved than say during 18-19. So next slide, please, Maggie. So other ways that we provide support through public health emergency preparedness and infectious disease outbreaks is we did receive some supplemental funding for Rocky Mountain Spotted Fever to support 5 tribal programs in the Phoenix-Tucson service area for impacted tribes. So that does provide a small amount of funding to communities that have been impacted. And we also work with our partners in the state to provide support. We also have worked with Cocoa Pod Tribe, and our success story is online to provide Casper-like data collection pilot. With COVID, we really were not able to get any additional Casper trainings in the works. We're revising that workshop, but now we do have some COVID response, several lines of COVID response funding and COVID tracking and training as well. Next slide, please. So then we were interested in knowing, who's attended our trainings in the past 5 years, and it's a pretty mixed bag, half and half. Half say yes, they've attended trainings, half say they haven't. Next slide, please. So which topics would your health department staff be interested in receiving training? You can see Excel came out really high, strategic planning as well, and visualizing and presenting data too. So, we did provide, the strategic planning with Bluestone, like we covered. And then Excel, we constructed a methodology where we would provide a training that included SurveyMonkey, Excel, and EpiInfo. But during the pandemic, we couldn't go out to communities with our laptops and work with folks one-on-one anymore, right? So we had to really pivot. And one of the ways that we did that is we worked with a professional group that Training to You, which is near us in Phoenix. And we contracted with them and opened up like a basic and then an advanced Excel. We had so many people want to do this that we had to open up I think it was another 12 sessions. So during the pandemic, it gave us this opportunity to work with a new partner and provide this training over Zoom. And it was pretty well received. I mean, it's difficult to toggle in between the speaker and the hands-on session when you're working on it. So I still think that there's merit to doing this in person. as well. But, you know, our communities really did enjoy working with the trainers, the Excel trainers from Training to Use. So we'll probably continue that relationship in the future as well. Next slide, please. So in response, here's some of the trainings that we provided in FY 17-18. Next slide, please. And then in 18-19, Dr. Davis provided the Google Earth trainings. If you're interested, he'll be speaking a little bit on that. We did grants, writing, digital stories, EpiInfo labs, RPMS trainings are always very popular. Next slide, please. And then in FY 19-20, so, you know, we did work on a qualitative data training, digital story. During the pandemic, one of the big focuses that we've been working on with our first responders and the folks in our behavioral health centers and our leadership is providing stress reduction training and support. So we did do an apothecary course for stress reduction that was 6 weeks. It was very hands-on. We had several people come and you would make a medicine or make some sort of item during the session, and you would have a group of people you could talk with, and a trainer from Southwest Texas that runs her own school. So one of the things that we made were lavender eye pillows for eye strains, since we're all working on our computers many more hours than we may be used to doing, since we're not having face-to-face meetings, we're doing Zoom meetings and things, and we all got to sit around and sew our pillows for our eye strain and talk about, you know, what's happening with us. So in a way, it's using that concept of talking circles that we know is proven and works. And, you know, we did have several people, you know, talk about their experiences during the pandemic. And it's just a really good way to be together during this time and reduce some of the stress that we're all experiencing. And then we also have an acupuncturist DO that works with tribal communities, particularly in Arizona, but across the country as well. And she's been doing massage and pressure points and body systems for stress reduction as well, for self-massage. You know, it's difficult to go out and get that type of support right now. So, you know, she was showing us how to do that, you know, for yourself. So that's something that has been really important to me, to make sure that we're all taking very good care of ourselves right now. And then Excel basic and advanced training, of course, was very popular. We did a tribally focused, tribal focus group training. Dr. Davis provided an online census.gov training. We did a COVID grant writing training when the OT 2004 awards first came out. And then we also did the COVID CRF Excel files. Dr. Davis pulled that together as well. So there's cost share on that. Next slide, please. So that's just a synopsis of some of our activities. It isn't completely all inclusive. I did try to focus around our main evaluation criteria for Congress, that when we submit, these are our main things that we are, I guess, graded on. But we do other things as well. And if you're interested in more on the tribal epicenters or more on Intertribal Council of Arizona, please let me know. I don't have a formal intern program as of yet. I would very much like to build something in. We have had interns in the past, and we do currently have a public health associate that's working with us. And I am working on an application for a public health associate to come in 21 as well. So, you know, there are training opportunities available. And then I do like to hire for actual jobs, for entry-level jobs. So, and we pay, you know, competitively with other organizations in the state. And we have an excellent benefits package that we stand by. So if you're interested in that type of information, you can always reach out to me. Like I said, it might take a little bit longer for me to respond due to the pandemic, but, you know, I do like hearing from students and, colleagues interested in research. So, just let me know how we can partner. And that's what I have for the afternoon. And I'll turn it over to Dr. Davis, and then we'll do questions at the end. Thank you.
So Dr. Davis, right before you get started here real quick, I just wanted to do a poll, a little survey of Dr. Ritchey's presentation. So I'm going to pull that up on the screen right now. So look for that on your screen. No,
I think, are you sharing your screen now, Maggie, or is Johnathan, Dr. Davis?
Dr. Davis is, so.
Yeah, so I think you need to unshare.
Okay, I'll unshare it.
Unless you want to just do it all at the end. Okay.
All right, so let me try that again. Oh, it's still not letting me pull that up.
We could do it at the end.
Okay, let's do that at the end. So actually, Dr. Davis, if you want to go ahead, we are ready.
All right, can everyone see my PowerPoint?
Yes, thank you.
All right, so I'm going to give you the brief 5-minute version of this presentation. Again, everyone, my name is Dr. Johnathan Davis. I've worked for ITCA as the Geospatial Analyst, the map maker, from 2014 to about early 2020. So I was the guy stuck in the back of the building in a dark room doing data analysis and map making. But once I graduated, defended my dissertation in March, Dr. Ritchey asked me to step up as this pandemic was beginning to take its hold in the United States and become the program manager for this program. My past research, particularly for my PhD, was in evaluating community-based land use planning. And I actually worked with the Navajo Nation and the Tohono Nation in doing community-based land use plans. And that included identifying processes that currently worked well within the communities, areas that were identified as needing improvement, and identifying strengths, weaknesses, opportunities, and threats within the community-based decision-making process within the communities. And this type of framework actually fits very well with what I'm going to talk about, which is the after action reviews that we conducted with the participating communities in Arizona, Utah, and Nevada with the COVID-19 pandemic response. So I'm not going to go into much detail on this. Dr. Ritchey did talk about the Intertribal Council of Arizona and the Tribal Epidemiology Center. So as you all know, as with previous health crises, tribes and Native communities have been disproportionately affected by the COVID-19 pandemic, often facing challenges such as lack of testing and shortages of personal protective equipment. And this is pretty consistent across Indian country. Many communities right now even are imposing very strict stay-at-home orders and social distancing regulations for their communities. So the purpose of this is kind of explain it after action and why we conducted the after action review. And this is also available on our website and the National Tech website, describing what we did. But an after action review is a structured qualitative review of actions taken in response to an incident of public health concern, in this case, the COVID-19 pandemic. Generally, an after action review is a simple, powerful tool used to assess performance, document lessons learned, and identify areas for improvement. An AAR seeks to identify actions that need to be implemented immediately to ensure better preparation for the next incident, and medium and long-term actions needed to strengthen and institutionalize the necessary capabilities of the public health system. AARs are designed to be flexible, and after action review can be adapted to fit the incident under review, as well as the organizations and systems involved. Stakeholders involved in preparedness activities should be those that are on the ground experiencing the pandemic, so they can provide relevant community-based, bottom-up and top-down knowledge on the incidents. And they should be able to assess the impact of the preparedness on the response from their direct experiences. An AAR features an open and honest professional dialogue, and it includes participation by all relevant stakeholders with the focus on the results of the incident and providing recommendations to improve performance. The success of an after-action review is contingent on the ability to bring relevant response stakeholders together in an environment where they can analyze actions. You're not hiring people outside of the community telling them what they should be doing. You're bringing in the people in the community on the ground, experiencing the response, and they're providing the information that they experience to your team to develop this after-action review. After-action reviews are not intended to assess individual performances or competencies, but rather to identify functional challenges that must be addressed and best practices to be maintained. An after-action review is not a critique or a lecture. It's not a judge of performance, and it's not a means to embarrass different programs. It's not a tool to blame. It offers the participants and relevant stakeholders an opportunity to translate their experiences from their response into actionable roadmaps or plans they can do better in the next time. The added value of an after-action review is its focus on collective learning and experience sharing with emphasis on the knowledge of the stakeholders. One way in which an after-action review can add value is by turning that tacit knowledge into learning and building trust and confidence among the various response areas. You know, for instance, many people didn't experience this pandemic the same way. You have people that have been staying home the whole time, don't have the same experiences as those that are you know, the direct frontline responders that are taking care of people. But they both had their challenges. They both had the things that they've had to overcome. And same with emergency preparedness, the police officers, the firemen that are responding to these different elements in the pandemic. They all bring relevant, unique perspectives to how they've had to address the pandemic and areas that can be improved. Ideally, an after-action review should be conducted as soon as possible after an incident or outbreak is declared by the community, or within 3 months of the outbreak, so that that knowledge is fresh and you're able to reflect as accurate your experience as possible. An AAR, an after-action review, aims to identify capacities in place before the response, any challenges that came to light during the pandemic, the lessons identified, and the best practices observed during the response, including the development of new capacities. An AR answers the following questions: what was expected to happen? What actually occurred? Why were there differences? What went well and why? What didn't work and why? And what can be improved? And these questions are addressed as a group from the unique perspectives of the organization, from the community. The general purpose of an after-action review is to seek to gather the following: unbiased observations in retrospect, establishing how actions were actually implemented rather than that they would have ideally have happened according to existing plans and procedures. It's an analysis of gaps, best practices, and contributing factors, identifying gaps between planning and practice, analyze what worked and what did not work and why, and identification of areas for improvement, identify actions to strengthen or improve performance, identify relationships within the state, the federal government, and the tribe to strengthen or improve. And it's an intentional critical thinking around an incident. An after-action review promotes team consensus. As a team, members work together during the after-action review to assess performance and identify lessons learned, and also develop strategies to improve. And also, an after-action review promotes cross-sectoral learning or interdisciplinary learning as a response to many complex incidents. The more stakeholders you can involve that are on the ground, more than just the health sector, but health sector participants in an after-action review can come from multiple sectors involved in response to provide unique perspective. And this sharing of information, these multiple people coming together, builds capacity for preparedness and response, and gaps and best practices are identified as community-based approaches. The benefits of an after-action review is that these generate quick results. It's collective organizational solutions that promote intentional critical thinking and build on team consensus. And these discussions can be documented through recorded video or recorded audio or written down, and getting many unique perspectives, and helps build the capacity for the next incident. And the critical thing about after action review as a community-based approach is that you are identifying unique solutions, unique capacity, strengths, areas to improve that are based on the community that you belong to. That you're not identifying what's the best practices for Arizona, what's the best practices for everyone, but unique, actionable directions to address your individual community's needs. What went well for your community, what didn't work well for your community, and how to generate capacity to address those in the event of a next pandemic or as this pandemic continues to unfold. And that's my presentation.
All right. Thank you, Dr. Davis, for that presentation. So unfortunately, we aren't able to get our poll up and working right now. So I will make sure to email it to all of our registered participants. So
Maggie, did you want me to try?
Yeah.
Sorry. Yeah. Well, first let me just say, Dr. Davis and Dr. Ritchey, thank you very much for those informative and data-rich presentations. It was very, very interesting and a lot of information. And we have some questions, but let's try to do this poll. I think, did I launch it? You should be able to see it.
Yes, it's been launched.
Yeah, okay.
Thank you, Carrie.
Okay, yeah. So I'll leave it up. How long should we leave it up?
You can watch the numbers kind of coming in on the right hand corner,
I see.
and then once it kind of tapers off.
Okay, we'll just take maybe another, I don't know, 45 seconds or a minute, do you think? How much time do we have? Okay. Do you need more time or are we ready to go? I'm going to give you 15 more seconds and then we're going to go to the questions. Two more seconds, one. Okay, great. Going to end the poll now. Great. And I'll deal with that later, but thank you so much. Thank you all for participating in that poll or the survey evaluation. And again, Dr. Ritchey and Dr. Davis, thank you for your questions. We have some that have been typed into the chat box, so I'll go through those, and then we have some that were emailed to us. First, how can tribes access and use health information and data better from the state? So in this case, from the state of Arizona, how can tribes better access the data the state is collecting? And I'll let either one of you respond to that.
Sure, yeah, so this is Dr. Ritchey. I emailed separately with Agnes. Thank you, Agnes, for your question. You know, it's gonna depend on the state, and it's gonna depend on how their systems are set up. And so I'll give Arizona example. The MedSys system is how infectious disease data is collected. And we do have several tribes working with the state on MedSys. But what happens is then the tribe needs to enter in their own data. So you have to have a data entry person locally to do that. So we find oftentimes the barrier isn't necessarily that the tribe doesn't want to work with the state or the state doesn't want to work with the tribe. It's having that support that's local to be able to do that data entry. We've seen that with some of the Indian Health Service data as well, that we need to have a person, you know, an FTE, they're entering the data in order to have it. So that's one of the challenges. And then also it needs to be somebody that's trained. So, you know, I mentioned our RPMS PCC training that we did. The RPMS system is pretty extensive. There's multiple modules. And, you know, we do experience turnover at the local level in our data entry positions. So, you know, that remains to be a challenge. And then we've also provided training and technical assistance on the diabetes package as well, and provided training in those areas. So, you know, working with IHS and with the state, I think is important for data collection support and technical assistance. And then we do also, we provided an Excel file that corresponded to the CDC and the Arizona State case report forms for COVID. So if a tribe didn't have access to MedSys or they weren't working on MedSys and they wanted to collect their own data on COVID and use either the state or CDC case report forms, we built that. It was available online. They could just download it and use it at their local facility. And then also remember, COVID data would be collected through Indian Health Service, and it also be, you know, potentially collected if they did their local testing events as well. So, you know, there's a variety of different data that's out there, using that as an example. You know, I don't necessarily feel like the states don't want to give tribes data. I feel the bigger issue is how representative is that information of the community once it's received. The state of Arizona does some really nice American Indian health profiles. They've done this over time. They do break down some of the information by tribe. It's all available online, but you can see the numbers get so small for most of our communities that it isn't usable information. So not only is data access important, but making sure that once the information is accessed, that it's usable. So that data quality piece is really a big key.
Okay. So let me ask two follow-up questions to that. So does this mean that when a state collects health-related data, unless a tribe goes in and puts in their own data into the same database, there is no data collected on the tribal communities? And then the point about the usable data and the numbers being small, is that just because the communities are small, or because people are not participating in the data collection, responding to surveys, for example?
Okay, so to answer the first question on quote unquote health related data, so that's a pretty big catchment statement. So, you know, maybe there's tribal data in there, maybe there's not. You know, with death reporting, we know there's tribal data in there. For the state, it depends on whether the state captures tribe or not. Arizona does. So, you know, in the death data for Arizona, we do have tribe on the death certificate. Some states, remember, are still on black and white, okay? So it's going to depend on what state you're in, because that's who determines what gets collected on something like a death certificate. Birth certificate, same thing. You know, it's going to depend on what the state is requiring to collect, okay? That issue becomes compounded with the national data. In particular with infectious disease data, we do have some tribes participating in MedSys. If someone was outside of the tribe, right? Say you were at Banner Good Sam and you got a positive test for, you know, I don't know, let's say cholera, just to make it interesting. You would go into the MEDSA system because that's a reportable disease. So the hospital would report that. They may not necessarily code that as a tribal member. They may not even necessarily code that as an American Indian person. Race could be completely missing at the lab and or the hospital. That's one issue that we're working on and we're seeing. So yes, there's tribal data in the state data, but it may not be identified as such. And you may not even have race and ethnicity. In our MMWR that we just recently put out on COVID, we only had 23 states that had enough race and ethnicity information to even do any analysis on it. So there's also a data transfer issue. So what I've got on the state ADHS's website for COVID by race and ethnicity is different than what they're transmitting to CDC. So to build a national narrative around health disparities, I find you're on shaky ground if I only have 23 states that have enough race and ethnicity data even uploaded to CDC to build that national narrative. So when I have community members coming to me and telling me that they don't feel that they're represented and that they feel that their community is quote unquote made look bad by this national data, I have to tend to agree with them because the data quality is so poor. I don't even know sometimes how these assumptions are made. Now, that is not the fault of CDC. That is not the fault of the state. It's nobody's fault. It's just the way that this is fell out. So there's a series of political, IT system issues, funding issues, and also we have a patchwork healthcare system. So remember, IHS isn't required to report to the state either. So that data and information is going to be within the Indian Health Service. Also, if a tribe is 638, they are not required to report that information to the state. So that information could very well be housed at the tribe and not leave the tribe. Now, if some states choose, or if some tribes choose to participate in the state infectious disease systems, remember then the tribe would have to enter that information in and upload it so it would go to the state and then go to CDC. And that would be on a case-by-case basis with the tribe as to whether or not it's going to be shared publicly as well, right? That would be in their data sharing agreements.
Wow. Well, that's really fascinating. We'll definitely have to follow up on that in the future. So we will be.
There's a lot of issues. We're working on several manuscripts now to shine light in dark places on this in order to work with our states and counties to get funding to improve these issues. But that doesn't necessarily mean it's going to remove some of those political barriers, right?
Right. Yeah.
So that can be a big issue too.
Right. And I think that's kind of what I was looking at, the policy.
And even if there's a policy in place, Carrie, there's policies in place in certain states and then they still just don't do it. Or then the lab doesn't code it or the county doesn't code it. And you know, like just because I have American Indian as sample doesn't make it so either, right?
Right, right. Yeah.
You know, okay, so well, then you run into that whole issue too.
Yeah. Yeah, we'll follow up on that. We have a couple more questions I want to get to because we're actually over time. So maybe if we have 1 minute response on these, but we can also follow up in writing. But one quick one is from someone who works with the American Indian Public Health Resource Center as a public health coordinator in Fargo, North Dakota. This is from Rachel Holliday. She sat in on a statewide visit with the Great Plains Tribal Epidemiology Center. One of the biggest concerns that came up during this meeting was that some tribal nations did not have access to COVID-19 data, probably for reasons you just said, although they were collecting the data through contact tracing and testing within their tribal community. Since then, the issue was fixed with our state. Did your organization provide any assistance or advice to other tribal epidemiology centers across the nation regarding the similar issue? And if so, what were your recommendations to the tribe? And if not, what are your ideas for addressing this? I think that you partially responded to that question in your response just now, but do you have anything else to add?
I did, and I didn't receive any queries from North Dakota or from PJ's group at Great Plains, so I didn't provide recommendations on this specifically. What I can say is, you know, it does relate to my previous statement. If the tribe is participating in the state data system and they're doing contact tracing and they're uploading their data and information, they should be able to download that data then and have it. That shouldn't be an issue. Now, as far as having people outside of the tribal jurisdiction, that may not be available to them. It depends on how they set up their data sharing agreement. But if they're doing their own contact tracing, it depends on how they were categorizing it too, whether that was going to IHS, whether that was going to the state, whether that was going to the county, whether that was going in an Excel file. It depends on how, they're doing data catchment. At the beginning of the pandemic, we did have some tribes in Arizona request TA on contact tracing. We did work with our states and counties to provide that support. Ultimately, by the time contact tracing, became a thing, we already had community-wide spread in Arizona. And once you have community-wide spread, contact tracing really is not very helpful, to be frank. It just is a wash at that point, and you need to do general public health messaging.
Right. I think, Maggie, do you think that's it for the questions, or should I?
That's it.
Yeah, we're over time, and I know everyone's so busy right now. It's amazing how quickly time goes. But we want to thank you both, Dr. Ritchey and Dr. Davis, for your very informative presentations, very helpful. And I know we will have follow-up to do. So thank you so much for joining us. We really appreciate it. And just as a reminder, a copy of this webinar and the materials that we can upload will be placed on the NNHRTI website, which is www.nnhrti.org. So those will be available shortly, not right away, but might take a day or two. But be looking for those. And also, if you're still on the line, please join us in January for the next webinar, which will be the last webinar in this series, January 13th at 2 p.m. Eastern time. And we'll send out information about that. But again, thank you all, and especially to our presenters. Thank you so much. And to Mr. Lopez, thank you for that opening prayer. But thank you all for being here today. We greatly appreciate it. And thank you for all the hard and important work you do.
Thank you. Back at you, and everybody have a wonderful day.
Yeah, thank you. Happy holidays.